free to share this webinar with colleagues who could not attend today. A question and answer session will immediately follow the presentation. If you have a question for our speakers, please type it into the questions box in your GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by WellBe's Guided Path. A guided care path helps create a single streamlined patient experience through the entire journey of a total joint replacement by creating a continuum of connection between patients, their families, and their providers. Smart checklists are delivered just in time as patients progress through their surgery plans and recovery. The information is always there for reference when needed in case preparation or follow-up instructions are forgotten. This helps reduce patient anxiety and improve outcomes. To request a free demonstration, visit us at wellbe.me. I'd like to introduce our speakers for today. Krista Fakori has been providing healthcare management consulting services since 2006. She has particular expertise in developing comprehensive orthopedic programs and designing alignment models between health systems and independent orthopedic surgeons. And Todd Godfrey, with nearly 15 years of healthcare experience, has a focused background in musculoskeletal services. He regularly advises clients on performance-based incentives between surgeon and health systems as organizations position their musculoskeletal service line to assume risk and manage populations. Todd, I'm going to hand it off to you, and you can take it away.
Great, thanks, Megan. As we turn our attention to the agenda, what we wanted to walk through with you today is go over some of the trends that we're seeing in the industry that I'm sure many of you are aware of, and then talk to you, turn the presentation over to Krista, who's going to talk to you about some of the new methods of payment and the implications of those on your service lines. I'll then walk through some of the hospital physician alignment opportunities that we're seeing many of our clients employ with their orthopedic surgeons, and then Krista will close us out with some closing remarks. I have to apologize in advance. I do have a cold, so hopefully I won't cough too much during this presentation. On slide 3, really, as many of you know, there is an expected growth of about 15 to 20% in inpatient musculoskeletal services. That is really a result of increased aging populations who are needing joint replacements. We're also seeing a younger generation of patients receiving joint replacements, age 45, 50, at an earlier age because of the technology and enhancements that we've seen with implants. And then, as we all know, the obesity epidemic has created a demand for orthopedic services that are embedded in these growth rates. The last thing really around insurance expansion, we're obviously seeing the increase for elective procedures as more and more people or as we see more and more people become insured. We expect to see the demand for services increasing. As you turn your attention to slide 4, one of the impacts to our hospital-centric service lines is really this shift from inpatient to outpatient that we're seeing, both from the perspective of joint replacements as well as spine-related procedures. And that shift is a result of a couple things. One is we're seeing reimbursement changes in the market. Many of you may have seen Medicare introducing as part of their SGR fix in the fee schedules for last year included a proposed payment for joint replacements in the ambulatory setting. That was not part of the final rule. We expect that to continue and eventually take place. But we are seeing commercial payers pay for joint replacements in the ASC, and so we've seen a shift in certain markets where we have progressive surgeons doing outpatient joint replacements, particularly in younger populations, age 50 to 60 years old, with no comorbidities doing a unilateral knee replacement in the ASC environment and discharging that patient same day. So really the drivers and the shift from inpatient to outpatient, I think we're going to continue to see, especially as we look for lower cost alternatives for musculoskeletal procedures. The last thing I would say in terms of volume and expectations is really around utilization rates. And so we expect to continue to see emphasis and scrutiny placed on utilization, especially around spine procedures, and see it in certain markets such as Michigan where Blue Cross Blue Shield is really employing non-operative management of back-related illnesses and conditions where you have to see a physiatrist or a pain management specialist before you can even get surgical consults. And so we would expect to continue to see those types of arrangements and requirements set up. As you turn your attention to slide 5, we wanted to talk just briefly about some of the trends we're seeing in reimbursement. And as you can see on the left side, the graph on the left side, professional fees, we looked at the top 25 CPT codes for orthopedic surgeons around the country and just looked at the changes in payments for those top 25 codes. And as you can see, since 2012, we've seen or since 2011, we've seen a cumulative change of a 12.5% decrease on the professional fee side. So our doctors are getting paid less for what they're doing, which is again no surprise. Well, our facilities have seen a relatively, a 3-4% change in their payments for musculoskeletal services, and so as we continue to look at payment reform and changes in payment, we expect these trends to continue. On the facility side, at least, flattening out and potentially seeing the continued decrease on professional fees. With that being said, as you turn your attention to slide 6, our physicians are continue to increase their competition. Our orthopedic surgeons have, over the past 5 years, compensation rates have increased 14% as we look at survey data. And this is survey data from our own internal compensation surveys. We've been doing a physician compensation and productivity survey for about 15 years. We have about 18,000 physicians in that survey, and so we've seen an increase of approximately $8,000 to $10,000 a year in compensation over the past 5 years. It's interesting when you look at productivity and as measured by work RVUs, we've actually seen a decrease as a result of changes from the survey this year, and we're still investigating what this big drop is from 2012 to 2013, where we see work RVUs go from 8,000 to 7,000, and then the associated ratios. This would suggest that our physicians are working less, though. However, per unit reimbursement is on the decline, and so the way that physicians, orthopedic surgeons, have kept the increases to their compensation is looking to ancillary revenue. So from the perspective of ASC revenue, ownership of PT and MRI services where it's legally allowed in states, but also where they've aligned with hospitals. So a little bit of employment, but I think it's a lot of alignment that we'll talk about in a few minutes around co-management, call coverage arrangements, joint venture type activities where they've been able to supplement their income in non-clinical producing ways. As you turn your attention to slide 7, we haven't seen the surge of employment as drastic in the market as other specialties such as cardiology, where ancillary revenue was really taken away from cardiologists from the perspective of in-office ancillaries, and was really a driver towards employment of the majority of cardiologists in the market. We haven't quite seen that yet with orthopedic surgeons. They're still allowed to own ASCs in many markets, still allowed to have physical therapy and MRI in their offices. And so the drive for independence and the desire to maintain autonomy has really kept our physicians, our orthopedic surgeons, out of the employment limelight. You know, in terms of looking to the future, I think we will continue to see some employment, especially as Krista will talk about, narrow networks forming and alliances forming to become the provider of choice for clinically integrated organizations for ACOs, et cetera. And so I think that we will see tighter alignment and potentially see employment rates increase over the next couple of years. And to summarize this section on slide 8, you know, in terms of drivers that are affecting all inpatient volume, you know, the penetration of ACOs, of clinical integrated networks, as organizations take on risk and are really trying to focus on cost, we expect to see a potential impact of a decline on inpatient volumes. Depending on where your organization sits on the cost and quality continuum, this could be a potential threat to your organization. With that being said, it could also be a potential opportunity for your organization if you are in that low-cost category as narrow networks form in your market. Obviously, coverage expansion, we expect to see that as a driver of volume to your organization as new populations seek care for elective types of procedures. In terms of drivers specific to orthopedics, you know, the demographic shift. So as we continue to see younger, healthier, active populations getting injured, the technologies that are available that weren't necessarily available 10 years ago for interventions are there. As we continue to see a focus on the overweight population of patients and the aging population, we would expect volume to increase. Technology is another driver. You know, innovative ways of treating conditions that were potentially implant type interventions. We're seeing organizations, we're seeing surgeons develop through stem cells, you know, newer, less invasive type procedures that are increasing utilization as well. As I alluded to earlier, we are seeing a decrease in our focus on utilization from the perspective of whether surgical intervention is necessary, is clinically integrated, and is the most cost-effective, leading to the best quality outcome. We're seeing, you know, CMS focus on this, and we're also seeing commercial carriers focusing on non-intervention, which again is nothing innovative or new to us, but as we understand the implications of this and the changes in reimbursement that are becoming more and more evident, we expect this to drive down volume. We already talked about the growth of outpatient surgeries and the shift from inpatient to outpatient, which is really a large threat to hospital-centric orthopedic musculoskeletal service lines. And so how are organizations positioning themselves to ensure that they're looking at the continuum of care and having the capabilities to shift and respond to this shift in a very strategic fashion is going to be important as we continue to see this competition for outpatient environments. And so with that, I'm going to turn the conversation over to Krista, who's going to talk to us about some of the payment changes we're seeing.
Thanks, Todd. If you turn your attention to slide 11, one of the things that Todd mentioned earlier on, and it's probably pretty obvious to most of you, is that the downward pressure on reimbursement is really driving a lot of these new payment methodologies to become more prevalent in health systems. And so what we've done is we've really picked, I think, the 4 that are most recognizable to orthopedics, and we wanted to spend some time walking through those payment methodologies with you today. I would say that the 2 largest trends that you probably experience and that our clients are experiencing are really is the shift from risk from payers to providers, as well as moving payment from the traditional fee-for-service focused on value type of environment to a value-based system where we're paying for performance and treatment and the population health types of services for our patients. What we've got listed on slide 11 here are 4 different payment methodologies. The first one, enhanced pay for performance or value-based purchasing. Probably all of you are more than familiar with this particular payment methodology. Obviously, the purpose of that methodology, the rationale is for health systems really to improve outcomes, reduce long-term utilization, and they do that by encouraging adherence to best practices and using certain metrics. The payment mechanism that's used for value-based purchasing is really financial bonuses, penalties, or withholds, and those sorts of things that are paid and tied to the performance. Bundled payments, we hear not just from the health systems a lot about bundled payments, but the independent orthopedic surgeons are asking about bundled payments, and it is something that is increasing its presence, at least in California, in terms of a really viable payment methodology for episodes of care. The purpose, the rationale for it is obviously better coordination of care and to reduce expenses. And the payment structure for that is really a single payment that covers hospital professional fee services, and essentially the purpose of it is to drive the physicians to coordinate with the hospital and to lower the cost of care provided in that. Narrow networks that we'll talk to more in detail as well. Essentially what this is a discounted rate provided to providers in exchange for volume or a patient network. That's something that, we haven't seen it increase as much, but there are certain contracts, for example, with Blues, where they have designated centers in which they're directing their patients that are becoming more prevalent in orthopedics, I would say. The 4th payment methodology is ACOs or other risk-based contracts. The rationale is obviously better coordination of care, keeping patients healthy, reducing unnecessary utilization, lowering the cost of care, all of the things that we're really looking to do. This is a more complicated payment methodology, as the total expenses for the population would be compared to risk-adjusted benchmarks, and then of course any savings are shared among the participating providers. On slide 12, we go through in more detail value-based purchasing. Obviously, as you look, and you're probably experiencing with Medicare, a deduction on your DRG patient payments of about 1% in 2013. I think it goes up to, close to 2% in 2017. So essentially, the payment methodology is that there's a deduction on your DRG payment, and by the end of the year, you report on certain metrics, skip, HCAPs, those types of metrics, and you earn performance that can meet or exceed your previous payments based on how you perform on those. That one is already in place. There's a lot of hospitals out there that are using this as a way to drive further alignment with physicians so that they can work on the skip metrics and patient satisfaction scores and those types of things. I think one thing that we've put on here that's interesting that will really impact the physicians in the future and drive further alignment with the health systems is the 2015 Medicare Physician Value-Based Payment Modifier. And that I think, in coordination with the work that's already been done in a lot of health systems for the value-based purchasing program, will be certainly a driver of alignment. On slide 13, we talk a little more in depth about the different other types of value-based purchasing, so more pay-for-performance metrics. On the previous slide, we showed you the Medicare ones, though they're probably what you're most familiar with. But there certainly are commercial payers out there that are deriving value-based purchasing and pay-for-performance types of metrics. And so this is just a list of a few of the metrics that we've seen other payers and health systems have arrangements around. So implant costs, and really that's focused on the product standardization, trying to minimize the number of implant vendors, trying to keep your joint replacement costs between $4,000 and $6,000. I think those are a lot of the focus of a lot of health systems, since it's a major cost of providing orthopedic services. We've seen a Blue Cross plan around the length of stay for patients and really trying to optimize the appropriate length of stay for patients based on the surgery that they're being provided. Obviously, avoidable admissions, and Todd had mentioned this earlier, so it's around reducing utilization of surgical treatments that may not be medically needed. And spinal fusions is a focus, at least for Medicare at this time. 30-day readmissions, I know that that's been all over the news, and so everyone's pretty familiar with that being a focus in terms of lowering that. And it's traditionally been pretty low, probably below 3 days, I would say, for most or 3%, excuse me, for most of the hip and knee replacements. However, I would say that what we're seeing is a lot of health systems focused on order sets, joint class attendance, those types of things that will help drive the entire episode of care, making sure that it's not just about that operational component of providing care, and so that we're making our patients, we're getting them the pre-op stuff that needs to happen, and we're making sure that we're coordinating the care after they've had their surgery. On slide 14, the next one, I think, again, it's another prevalent one. We think it will continue to increase, especially in orthopedics, and it's bundled payments. And with bundled payments, for those of you who are not familiar with that, it is essentially a set fee that is paid. Basically, the hospital typically holds the contract. It includes both the facility and professional fee payments for both the visit or the episode of care and any readmissions. So obviously, the incentive here is to have low cost of care, to make sure that your patients aren't being readmitted, and essentially the payers get their benefit because there's a discount percentage applied to the bundle, but the surgeons and the hospital can share in any savings if they're able to lower the cost below what they've been previously producing at, or whatever the payment, however the payment has been set. I think one other thing just to mention on this page is that not only do bundled payments have the lowering the cost aspect that many organizations and physicians are looking to drive, but also the quality component of it. It requires a stronger coordination of care, and it's been shown to lower complications, readmissions, and shorten lengths of stays. On slide 15, we go in further into the bundled payments, and this is something that I think is a little bit new, and we've only seen it at a few organizations, but we've heard that it has strong impact in its ability to lower the costs within a bundled setting. Essentially what I'm talking about here is demand matching. And demand matching is really, it's an attempt by the hospital and physicians to basically improve implant selection based upon the patient needs. So what you have is the multiple clinical factors, age, weight, their activity level, their health, their bone stock, and you use those factors to determine what's the appropriate implant for your patient. Of course, all patients are saying, what if I wanted to someday run a marathon? I want the best implant. And maybe you have, for example, an 82-year-old active male who is golfing and he's biking twice a week, and he says, I'm still very active for 82. Does he really need the same implant as an Olympic athlete who maybe is working out 5 to 6 hours a day? And so it's really trying to align the implant selection with the appropriate, or with the patient. and their clinical diagnosis. And so I think there's certainly opportunity here. It goes beyond the standardization of implants, which a lot of organizations are focused on right now, but it's taking it one step further and saying, let's evaluate our patients and then within our standardized implants, pick the appropriate ones. Something else to mention on this page as well is other things that our organizations who are participating in bundled payments are looking at are really the site of service. So there are some efficiencies or lower cost settings within a larger health system. So whether or not the surgery should be performed at the hospital or at an ASC, as Todd mentioned earlier, ASCs are typically lower cost settings, and so that could also save on the amount of cost of providing the service. Another thing that I've seen other organizations focus on is transitions. So as the hot patient completes their inpatient stay and the transition to the rehab facility, making sure that those transitions are occurring quickly. On slide 14, we just go over again a few of the benefits of the bundled payments. I think you're all probably familiar with the quality and decreased cost outcomes of the benefit of the bundled payment projects that are currently in place. But I think, as Todd mentioned earlier, there's some intangibles in terms of the physician alignment component here that are becoming, I think, a good way to create this sort of deeper relationship with physicians and really align their behavior with the things that you're trying to accomplish at your organization. Gain sharing through a bundled payment is one way to do that, but also through the volume. You're both looking to have the patients and secure them in your network. And one of the things that, patients, as they become more educated, they're looking for a predictable expense. They want to know that they're going to get quality for the amount that they're spending. And with bundled payments, it's a more clear, straightforward form for them. We talked about earlier the wave of the future. We do think that this is something that will continue to increase its prevalence, especially in orthopedics, and so it's not to be ignored. On slide 17, we talk about narrow networks. And narrow networks are essentially, basically it's where a provider will take a discounted rate for the services that they're providing in exchange for basically guaranteed volume, as much as you can typically guarantee volume, that is. We've seen it in two different sort of settings. One is sort of the peer-driven model. This is an example. On the top is the Blue Shield Blue Distinction Center model. We've seen that in a couple of organizations throughout California, where essentially for hip and knee replacement surgeries, the orthopedic surgeons have to submit an application that basically they fill out, they show all their performance on certain outcomes that are designated by Blue Cross. And what happens is essentially if their performance meets the goals of Blue Shield, then they become a Distinction Center. They also have a Distinction Center Plus model as well. In exchange for providing services at a certain quality level, Blue Shield then directs their members towards those centers. Another example is employer-driven methodology. We've got an example of two large Fortune 500 firms here, and essentially what they did is they redesigned their self-funded employee benefit plans to essentially direct patients to the providers that were aligned with them. So what they did is they made the benefits were reduced for out-of-network providers. So if the patient went to somebody who's not within their network, their copay would double. They would have reduced benefits, so they would have larger out-of-pocket expenses. So that would drive the patients towards the providers that these employers were looking to do so. In exchange, the providers would accept a discounted rate. Now, they did have something interesting in here to protect the providers. So if the higher volume that they projected they would have did not come, then what happens is in the next year, the unmet volume would trigger an 8% rate increase at the start of the next year. Okay. On slide 18, we talk a little bit about some of the other risk-based contracts. Of course, what we don't have mentioned in this presentation, clinical integration, full risk, that sort of thing. But this is really an ACO type model that we see continues to be prevalent. And essentially what we're looking at is a comprehensive care delivery network. While right now a lot of the pilots are focused on primary care, we're expecting that as they incorporate specialists into their network, it will be increasingly important for both hospital service lines as well as orthopedic surgeons to make sure that they're aligned with these ACO structures so that they're not sort of left out of this network. And one of the ways that they can do that is really proving that they can manage the cost of care as well as the delivery of that care. So if we go to slide 19, this basically shows, and similar to WellBe and the services that they're offering, it's really about being able to demonstrate that you can manage the patient through the entire care cycle. So starting with the preventative care, the joint class attendance, the non-operative care, and going through past the operative treatment to the post-acute treatment. I think, what we want to make sure that everybody understands is that we're not saying to health systems to go out and provide all of these services necessarily if that's not within their purview, but it is to make sure that when they're developing their service lines, when they're thinking of these services, they need to make sure that there are these links in place, because you will not be able to participate in bundled payments or other types of risk-based contracts if you're not able to keep the patient healthy once you've performed that surgery. And so that's just something that we wanted to make sure that you understand going forward. I think one of the things, too, that just to point out on this slide is you can't just do this being a health system. You obviously need the physicians to be an integral part of managing the patient. And so with that, I'll turn it over to Todd, who will talk through the hospital physician alignment mechanisms that we're seeing for orthopedics.
Thanks, Krista. So as we look at slide 18 and we think about the driving forces for physician alignment, we've talked about some of the factors that are increasing the demand for orthopedic services. Krista walked through, the changes in payment methodology from a fee-for-service to assuming risk. As you think about how you do all that, you obviously need your physicians at the table, engaged in your organization and dedicated to developing the program, to ensuring that we're doing it in a cost-effective, high-quality manner to produce the best outcomes so that we can position our organization to become the preferred provider, to negotiate with employers, to do direct contracting for certain procedures, and those sorts of things. It's interesting, one of the things that I think a future webinar presentation will speak to is really how you develop that system of care across multiple campuses with an inpatient focus, and then incorporating that ambulatory care strategy so that you really are able to achieve that continuum of care that Krista alluded to earlier. As we look to the drivers, we're seeing many younger physicians coming out of training, seeking that employment arrangement and really not looking at that business model, that entrepreneurial model that has been successful in the past. And so I think we will continue to see the desire for employment of orthopedics, especially in markets where we do not have a large, successful private practice that is able to recruit and retain orthopedic surgeons. I think we will continue to see professional fee at least flatten out, if not decline, which will affect the practice economics of the private practice model. And as reimbursement changes, we need to be prepared in our organizations to ensure that we're able to provide a place of service for orthopedic surgeons and physicians that might not be able to continue in private practice. The need for capital is a huge driver as well. Private practice physicians traditionally do not invest a lot of money back into their practice, and so the need for EMR and the investment that's required, and then the subsequent investments to plug into the different systems are a large capital expense that are driving physicians towards hospitals for capital. Call coverage continues to come up, and the many orthopedic surgeons are looking for call coverage arrangements for payment for that service, and traditionally aren't relying on the emergency room for building their business as they traditionally had been. And so how are organizations positioning themselves to respond to call coverage requests? The degree of specialization within the service is a driver as well. We're seeing more and more surgeons want to do just joint replacements, just sports medicine, arthroscopy-related procedures. And so that creates a split between the inpatient and outpatient world, and really different needs, especially in markets where we have private practices owning ASCs and some orthopedic surgeons not even coming to the hospital anymore. And so what are those implications? The uncertainty of reform, many private orthopedic surgeons we've had conversations with just become employed because they are uncertain and they don't want to deal with it anymore. They don't want to have to be at risk for the reimbursement changes that are coming down the pike. And then obviously the importance of demonstrating quality and the investment that's required to do that. The data collection, the reporting, the monitoring, all that sort of stuff requires resources that many physicians are looking to the hospital for. And so, I think that the key takeaway from this slide is really that there's many drivers, and it's very market specific. And so we really need to understand what our drivers are to develop the appropriate alignment vehicle and model that's going to allow us to successfully achieve our strategic initiatives, our growth initiatives, etc. And so as you look at slide 19, you can see some of the models. As you look at the continuum from left to right, I imagine many folks on the line have medical directorships with their orthopedic surgeons. The traditional medical directorship is increasingly scrutinized, and so now we're seeing organizations put performance incentives around those medical directorships. It's now not just recording the hours that you're putting into, but it's demonstrating that you're doing something with your time, that you're driving quality, that you're driving cost initiatives as a medical director, and really tying payment for that activity to those metrics and goals. A leadership council, many of you with service lines probably have some form of a steering committee, a leadership council that is made up and comprised of orthopedic surgeons, maybe anesthesiologists, other types of physician providers, and hospital administration that meet on a regular basis to set the strategy, set the budget for your service line, and manage the day-to-day operations of that service line. We're seeing more and more ASC joint ventures pop up, either to give physicians the opportunity to participate in ancillary revenue and bolster their income, but also put them at risk so that they stay in the game, so to speak, and stay engaged in the development of that facility. Co-management agreements, I think we're seeing more and more arrangements pop up in orthopedics, especially around ambulatory type facilities. So we've done a few co-management agreements and participate in the development of the incentives for freestanding ambulatory centers that have outpatient operating capabilities that have MRI, CT, plain film radiology, physical therapy, and then supporting physician practices from the perspective of primary care, maybe even cardiology and other supporting providers that participate in the care of the musculoskeletal patient. We're seeing co-management arrangements pop up to help manage those centers, and so I think that will continue as orthopedic surgeons want to keep their independence. I think we'll see those types of arrangements continue to pop up. And then the overall management of physician practice, from a lease arrangement through professional services arrangements and management services agreements, all the way over to employment. So I think we'll see more and more of these types of arrangements in orthopedics as the need for alignment increases. As you shift your attention to slide 20, again, speaking to the ASC JV opportunity, don't want to spend too much time on this, but from the opportunity perspective, it creates the low-cost, high-efficiency environment to do cases in. And so, and in markets where we have hospitals and health systems not necessarily have this capability, we're seeing them go out and acquire it. In others where they do have the capability, we're seeing them joint venture and bring physicians in to help manage those opportunities. And for the physicians out there, that are looking at it, we're going to see continued downward pressure on reimbursement. We're going to see the disappearance of out-of-network billing, and so that those margins are going to start to erode, I think. But it is still going to be an attractive facility to do a majority of cases. When you look at slide 21, this is just to depict a structure for a co-management agreement. That's not to say that this is the end-all, be-all for co-management agreements, but this is a typical model that we see, where we see a group of physician investors that may or may not pay an initial minimum startup in capital to form a new management company. That management company is then contracted with the hospital to oversee the service line management oversight, which in turn pays payments back to the management company for equity distributions back to the physician group. Typically, there's a governing board of that management company and some type of committee structure underneath that, from the green circle governing board down below could be reminiscent of your service line structure. And then if you're looking to implement, you would layer on top of that the management company to provide the vehicle for payments or for management and oversight of your service line. We see these arrangements work really well when the goal isn't necessarily financial. When we want to give physicians the opportunity to participate from a financial investment, but the arrangement isn't specifically driven by financial need. On slide 22, we wanted to just speak to you briefly about some of the metrics that we see, and we typically see co-management agreements in the component, the incentive component of the co-management agreement, looking at 4 buckets from quality, operational excellence, satisfaction, and access. From a quality standpoint, we're looking at, typically skip measures, readmission rates, antibiotics and selection and delivery, those types of things that we already measure today, and we're looking to drive performance. Operational excellence is typically geared towards the OR from the perspective of on-time starts, staffing, utilization rates, etc. Staffing, we look at, physicians, referring physician satisfaction, patient satisfaction, etc. And then this notion of access, really to ensure that our providers and our physicians in linking things to the ambulatory environment to say, are we providing the best access? Are we getting back to our patients in a timely fashion? Are we meeting our call coverage requirements from the perspective of preventing unnecessary transfers to other facilities and those sorts of things? It's important to note that on the performance incentives, we really need to we need to pay for increased performance. So if our baseline is 99 or 100%, typically we would see organizations not focus and pay physicians on those types of metrics because there's no improvement opportunity. So it's really focused on demonstrating improvement from a baseline performance and using benchmarks to help set what the appropriate target is. And then employment on slide 23, as many of you are aware and potentially employ orthopedic surgeons. We have a couple different models where we can directly employ them, and they are, their own group underneath an employment umbrella of our organization, to something, a little bit more structured in terms of they're incorporated into a medical group, which is a wholly owned nonprofit subsidy that allows greater physician autonomy and allows us to pay people a little bit differently, and potentially own some ancillaries. And then going to the extreme of an employment model where we have a for-profit subsidiary that physicians and staff are a part of and really function on their own to make a profit and reinvest the dollars into the organization, and et cetera. So, those are the types of alignment. And again, I think that the presentation, you may say that it's somewhat high level, but each market is really independent. And so our hope was that we were able to leave you with some things to think about in terms of the drivers that are forcing organizations to align with the orthopedic surgeons, but not necessarily employ them, because we know that is a huge investment for organizations to employ surgical subspecialists. And is that the right model? Are there other models that will allow us to invest a little bit less and get a better return on our investment? And so I'm going to turn it back over to Krista that's going to wrap us up, and hopefully we'll have a few questions asked.
Sure, and I don't want to take too much time on slide 26 here, but just to sum up, again, orthopedics, we're not at the point yet where we can only focus on providing value to our patients. We still need to also ensure that we've got the volume. And so that means from a value perspective, we've got to lower our costs, we've got to focus on improving quality, but we also need to ensure that we've got the physician network that's aligned with our service lines as well as the patient base. And so again, the things that I mentioned in terms of the new payment contract, payment methodologies are a way to keep that physician network aligned with your organization. Also to keep the patient base as well. A couple of the other points on the slide we talked about, and Todd mentioned again, ensuring that we've got complementary services so that we're managing across the continuum will be important for the quality improvements that we're going to be asked to make in the future. The alternative payment methods, the 3, 4, and 6, those are all pretty much tied together. Essentially, what it speaks to is partnerships between physicians and health systems. New payment models, as well as being able to manage the payments or to manage the care across the continuum, the increasing competition that you'll be seeing from ASCs and this concept of medical tourism, all of those types of things are going to drive deeper alignment between health systems and physicians. And so that's just something that we're seeing with the co-management arrangement, with the payment methodologies. All of those services are really aimed at creating this deeper integration between the physicians and the health systems. Point 5 here also speaks to that, because we're seeing that the employment rate is not increasing exponentially to the point where that integration becomes natural. The approach will need to be more pluralistic in terms of needing to use the management methodologies, the payment structures that we've talked about today to tie the physicians to our health system. And with that, I think I'll turn it over to questions.
Thank you, Todd, and thank you, Krista, for that information-packed presentation. For those of you who are wondering, you will get an email tomorrow with a link to the recorded on-demand version of this webinar and a link to the PDF of the slide set. So if you're furiously taking notes, no worries. You can go back and reference it. We will now open it up for questions. If you have a question for our speakers, please type it into the questions box in your GoToWebinar panel on the right side of their screen. While attendees are, I wanted to remind everyone that today's webinar is sponsored by WellBe's Guided Care Path. A guided care path helps create a single streamlined patient experience through the entire journey of a total joint replacement episode of care. It does this by creating a continuum of connections to their families and their providers. Standardized care paths like these are essential if you're working with a bundled payment or other risk-based program. If you'd like a demonstration, just respond, and I will read the first question that we have. All right, how do you see practitioners dealing with the January 14 WRVU reduction for total hip and total knee procedures?
So, I mean, any reduction in productivity is obviously detrimental to the physicians because unless they're employed and on a straight salary. So the changes in work RVU calculations are obviously going to have a negative impact on physicians, and so anytime that happens, we typically see physicians trying to increase their volume, right, to make up for that. And so it's important, as Krista alluded to try and get out of, if we can, especially for joint replacements where there's evidence that bundle payments work, that where we try and get out of the fee-for-service environment and not reliant on the professional fee, where we can bundle all that and maximize our reimbursement. So larger groups, I think, groups like the Rothman Institute, groups like Hoag out in California are really looking at moving towards the risk-based contracts as quickly as possible, so that they can, so that they're not being impacted as negatively by changes in work reviews, changes to, or potential changes to the SGR, et cetera. And so, the couple strategies to summarize, I think, are if you're living in the fee-for-service world, that it's volume. You make it up by volume, but also looking at strategies to not be as reliant or dependent on the fee-for-service world and developing bundle payments.
And if I may add just to that, I think that goes perfectly with your last comment. I think what I'm seeing, at least in the California market and in some of the western states here, is that the physicians sort of understand that the writing is on the wall, especially for some of the work RVU values, some of the ASC reimbursement pressures that they're facing. They understand that to maintain their compensation at historical levels, they need to find these alternative revenue streams, and those are a lot of the methodologies that Todd walked through in terms of co-management arrangements. I would say, 5 to 6 years ago, a management service arrangement was something that a health system was really looking for, because they were trying to get the physicians engaged, and they thought, well, if we can somehow pass them some revenue, we can align them with the types of quality metrics outcomes that we're trying to drive here. What I've actually seen recently is independent physicians coming together saying, we need to improve quality. We know that we're going to start being penalized for, for not providing services that are high quality, and we know that our reimbursement, our revenue is going to be pressured in the future. So how can we align with the health system, improve quality, and also find an alternative revenue stream to diversify it?
Great. How does organizations structure the government, both employed orthopedic surgeons?
I think you broke up on my end, but I think you asked how you structure the governance structure when you have both employed and private practicing orthopedic surgeons. Is that correct?
Yes.
So I think that there's a couple different ways. The simplest, easiest way, which we have done in a few organizations, is simply putting a co-chair position in your leadership council, in your service line, management group, whatever you call it, so that you have an employed doctor and a private practicing doctor working in concert as co-chairs to set strategy, etc. The challenge always is when you have employed and non-employed physicians is, the non-employed physicians are always going to be feeling like second-class citizens because the organization isn't investing as much money into marketing, into the growth of the group as they are their employee group. And so the way that we've seen organizations kind of address that issue is through that leadership council, and then communication, so that the leadership council is really making decisions, and we're executing on those decisions per that council. It helps to mitigate some of those challenges and risks that you have.
Great. As we continue to see consolidation, what strategies are organizations adopting to grow their orthopedic programs?
Chris, do you want to take that, or? I'm happy to. So I think that from a system perspective, we're seeing more and more organizations think about how we look at orthopedic services across the system. Are we duplicating services, and does that make sense? What's our consolidation strategy look like? And then therefore, what's our backfill? So there's implications of outside of your orthopedic service line for consolidation, because we have to make sure we can backfill into any facility that we're taking cases out of and trying to consolidate. But I think as we look at the cost and quality continuum and think about what are the drivers of lower cost, it's repetition and standardization. It's being able to do the same thing over and over again repeatedly. And then some of the drivers of quality are being able to do it really well and efficiently, but also doing a lot of them. So organizations that are doing, 400 or 500 joint replacements a year versus those that are doing 20 or 30 are going to be more attractive, because I think that they're going to have better quality outcomes because you have surgeons that are doing the same thing over and over again and are really good at it. And so, thinking about how do we consolidate so that we have high volume to drive our outcomes in a very efficient, cost-effective manner is going to be important, whether we're one hospital or 4 hospitals. And then the challenge is how do we consolidate services if we're 4 hospitals and continue to address our patient needs of migration, so that they're not driving past other hospitals, and giving them options as well. And so it's incorporation of a hospital-centric model, but it's really looking at how do we take our hospital-centric model and become much more ambulatory focused with an inpatient hospital component.
And I apologize, I was on. Oh, go ahead.
Go ahead, you're on mute.
I was just saying I was on mute earlier, so I just wanted to add to that I think my advice to health systems out there is to be strategic in the consolidation. We see a lot of organizations right now that are just consolidating to get larger without thinking through the management expertise, the care coordination, some of the physician dynamics that exist with the organizations that they're consolidating with. And I think those 3 factors, if they're greatly aligned, you've got set of well-managed services either within an ASC or another health system, and you've got the right physician alignment mechanism, then it makes sense. But if you've got a health system out there that you're looking at just expanding because they also have a bunch of independent orthopedic physicians going to their hospital and there's no real alignment there, you're better off if you've got the capacity in your own system finding a way to align with those physicians versus just consolidating to consolidate.
Thanks. Well, we're at the top of the hour, so that's all the time we have for today. If you have questions that you didn't have a chance to ask, feel free to email them to info@wellbe.me, and we'll connect with stuff. Everyone, watch your email tomorrow for a link to the recorded presentation PDF slide set. Also watch for our next webinar from orthoserviceline.com in January. We'll be with the Hospital for Special Surgery. So thanks, everyone, and have a great day.
Thank you.